Thank you all so much for having me. I really do love to do these presentations and give people a sense of, what's going on in the field and really get to, make sure that patients and caregivers and others have, a deeper understanding of why we all talk about colorectal cancer so much. So we can go to the next slide. So today we're going to talk a little bit about biology. We won't get too deep into it, but it's important that you understand why screening for colon cancer works. And then we're going to talk about the screening recommendations and options. What I really say is, the goal of these kind of meetings is to make sure that nobody in the audience ever has to see me in a clinic. So again, I've been treating patients who develop colon cancer now for nearly or probably over 20 years. But I'm also not just a physician. I am a customer. I've had 2 colonoscopies myself because of a family history. I've gone through the procedure twice, so I can, I know it from what I speak. So you can go to the next slide. So, again, we're going to talk a little bit about, what is it from a biology standpoint? How common, how does it develop? We'll talk a little bit about risk factors and then, some of the important things that you can do to prevent it. Most importantly, obviously being screening. So we can go to the next slide. So just to begin with, the colon essentially has one major role in the body, and that is to absorb water. Unlike the rest of the bowel, etc., it doesn't provide a lot of, it doesn't do a lot from a nutrition standpoint, but its job is really to recoup a lot of the water that sort of gets put into the bowel so that the body doesn't get dehydrated. The colon itself, is situated like you see it here. And when you read about colon cancer, or people talk about it, we use a lot of different words, right? We talk about ascending colon cancers. And what we mean by that is the right side. And the reason we call it ascending is because, we start at the mouth and then, end at the anal, area, which is, where the stool comes out. And so if you think about it that way, everything enters in here on the right side where you see cecum and ascending, and then kind of moves its way leftwardly and then out. So it kind of goes up and comes down. So that's why we call that the ascending colon. We also sometimes you'll hear something that we call proximal colon, and that's just medical terms for the nearer side. And the nearer side, again, is defined as nearer to the, we lost the screen, yeah, is nearer to the mouth. And then the other side we call the distal side, and that's the left side. And we've actually learned a lot over the years that the right side and the left side are actually different, and they're different, from a biology standpoint. And then you've got the rectum, which is this last about 10 to 12 centimeters. And the rectum, although it performs a similar function as the rest of the colon, has a special place for us from a cancer standpoint based on its location. And so often when we think about rectal cancer and treating rectal cancer, we think about it a little bit differently, but the screenings that we're talking about will work no matter where, in the colon the cancer is. So we can go ahead and take a look at the next slide. So as we talked about, it's a very common cancer. So what you'll often hear it is the 3rd leading cause of cancer. But let me give you a couple more statistics on it. It is actually the #1 cause of cancer overall for non-smokers in all age groups. The other thing is we've just learned in some data that were presented by the American Cancer Society that for men under 50, it is actually now the #1 cause of cancer death for men under 50. And for women, we expect it to be the #1 cause of cancer death by 2030. And part of that is that we are seeing a rise in younger people getting colon cancer. Now, for reasons that we don't know. I mean, there's a lot of discussions about diet and exercise and et cetera, but we're seeing this across the world, actually. It's not just in the United States. We're seeing this throughout Europe, this rising incidence. Now, it's important to understand that colon cancer is still a cancer of aging. So the likelihood of getting colon cancer is much higher in older age groups. But when we take a look at kind of a year-on-year percentage change, we're seeing very dramatic rises in the younger population. And I'm including people here even to the age of 25. So that's why it's very, very important. And the thing that we try to stress to doctors and everybody else out there is not to blow off symptoms of younger patients, who may be having blood in the stool or pain. Often these things get, chalked up to hemorrhoids, etc., but to really begin taking, that a lot more seriously. And obviously the main theme and takeaway point, if you listen to nothing else that I say, is that colon cancer is preventable. And we know this. And the reason we know this is, one, we understand the biology of it, and I'll show that to you here in a second. But number two, we've been doing colon cancer screening for a while now, and what we have seen is a dramatic decrease in the number of patients overall getting colon cancer. So while younger patients were seeing a rise, if you look at the rest of the population, since we really instituted screening, we are seeing colon cancer diagnosis rates and colon cancer death rates go down substantially in the United States and really across most of the developed world. So we actually have actual empirical, so real world evidence that this works. So it's not just the scientists here telling you we think it works. We know it works and we've watched it work. And it is probably one of the most preventable of all of our cancers. If you go to the next slide, and we start talking about how it develops, this is why it is such a preventable cancer. So when you think about other cancers, like, say, breast cancer or prostate cancer, or even lung cancer now, where we are doing screening, when you do a screening test for that, what you're looking for is actually cancer, right? So for the most part, we are diagnosing cancer in those cases. For colon cancer and the other cancer where this is true is cervical cancer, we're actually looking at things that are not yet cancer, right? So what we call precancerous. And if you can take out something before it becomes cancer, then you prevent the cancer from developing. And so colon cancer develops from these little things, called polyps. And if you go, and this is really what, when someone is doing a colonoscopy, this is what they're looking for, right? They're looking for these little things growing. They look like little mushrooms, kind of growing out of the colon. And when we talk about some of the, the stool-based tests, the thing about these polyps is they tend to bleed. They also tend to shed some abnormal DNA, and we can pick that up in stool as well. So when you hear about our stool-based testing, we're really relying on blood and sometimes some of the genetics of the cancer to be able to sort of say, gee, I'm worried there's something going on in there. So if you go to the next slide, and this is really, where screening becomes, incredibly helpful in colon cancer. So now, going on probably almost 50 years ago now, somewhere in that vicinity, a group out at Johns Hopkins, really mapped out what it takes for a normal colon to become a cancer. And it basically, it's not easy to become a cancer. So to become a cancer, these things have to develop problems in their genes over time, right? So this is sort of the normal colon. And that process, for the most part, takes about 12 to 15 years. So from the very early signs of a precancerous polyp to an actual cancer developing for most patients. Now, there are exceptions, but for most patients, it can take 10 to 12 years. So when you hear about, colon cancer screening and colonoscopy every 10 years, that's what this is based on. That we know if we screen you and we don't see any polyps now, you're probably good for another 10 years because it's just unlikely that a cancer is going to develop in that interim. Again, we'll talk about some exceptions to that rule, and really that exception comes down to family history more than anything else. But we take advantage of this kind of slow process to allow us to intervene at a very early point. And if we get the polyps out, they can't become cancer. And if they can't become cancer, then the patients don't develop cancer. We can go ahead and go to the next slide. So, again, as we talked about, symptoms are not very common with the polyps in most part of the colon, because the truth is the colon doesn't actually have any pain receptors on the inside of it, which I know is surprising to people. Now, we all are very thankful that that's true, because you don't want to feel what's going on in your colon at all times. But the negative side of that is if a little polyp develops there, there's no reason that polyp is going to cause anybody any pain. So it's very common that people feel absolutely fine. They have no issues whatsoever. And then we go in and do a colonoscopy and, can find a polyp there, and you just never know about it. Now, having said that, there are some patients that will come with symptoms. And what are the symptoms? Well, certainly blood in the stool, right? Blood in the stool is the one that, is most concerning to us. Now, this always is very confusing to patients because, again, sometimes people will have hemorrhoids and they'll see bright red blood in the stool. I mean, the bottom line is if you see blood in the stool, this is something, that you should talk to your doctor about. We can often, based on the history and everything, make a determination how worried we are about it being cancer or not cancer. But truthfully, the bleeding of colon cancer tends to be much more subtle than that. And you may not even notice it. So sometimes what will happen is if blood sits in the colon for long periods of time, it actually turns black. So sometimes what blood looks like is just very, very black stools. Now, of course, iron pills or other things that can do that as well. And that's why a lot of our tests, are very sensitive for looking at blood, even if you don't see any blood there. Certainly, a lot of my patients, who have especially colon cancers that are further down. So again, remember we talked about left side, distal, lower, lower down in the colon. What happens is as the colon takes up fluid, stools become much more solid as you get to the end. And so as you start getting to the end, if you have something there, it's more likely to get blocked. And when you get blocked and the colon actually gets bigger, that does cause pain. So, and it irritates it. So sometimes people have more bowel movements than usual. Sometimes they'll see that their stool actually changes. It goes from being kind of a normal torpedo looking sort of thing into, much more stringy because it's getting compressed, by a tumor. The other thing that we look at are blood counts. So sometimes people will come in and we'll see that they have low red blood cells, which we call anemia. And the reason for that is when you bleed, you're losing iron as well. And iron is kind of the fuel for us to make blood cells. And so if you're bleeding or losing iron, then your body can't make as many blood cells. So often when we see a patient with, an anemia, one of the first things that we ask is, have you been screened for colon cancer? Because that is often, one of the most common reasons for patients having iron deficiency anemia. And of course, unexplained weight loss is always a red flag to us as doctors. People who are losing 10% of body weight and aren't trying to do so, we very much worry that means there may be something going on in their body. But again, if I'm, a take home from this slide is, yes, the symptoms are something that you should discuss with the doctor and make sure that they take it seriously, even if you're younger. But for most people, you don't want to wait for symptoms because usually by the time we get symptoms, that's usually a time where things are a little bit more advanced. So our goal is to figure this out before you ever know if there's anything wrong. And that's kind of the ideal world. You can go to the next slide. So, risk factors. So certainly, as I said, age. There's no question about it. We know this statistically, and we've watched this again over, now many, many years. The older you get, the more likely you are to get a variety of cancers. It's just, as our cells get a little bit older, just like the rest of us, they don't, often work quite as well. And sometimes they, develop, problems. So cancer is, and, always will be a disease of aging. But because of what you heard a little bit earlier, which is we're starting to see this rise in younger patients. Again, we don't know exactly why it's happening, but we know it is happening. And after many, many years of advocating on many of our parts, we have lowered the age to recommend colon cancer screening from 50, which I think, for people who have paid attention to this world, that 50 number is stuck in your brain. Sometimes I still make the mistake and use the 50 number. But because this is a change within the last year to 2 years, we've moved it down to age 45. And that is because we want to try to pick up, some of these earlier cases. The other thing, and probably the most important, is family history. All right. So the thing that I plead whenever I talk to patient groups and other groups is know your family history. So take time. So here we are in a holiday season again with Easter and Passover and other holidays, and where people are going to be spending time with Ramadan, and people are going to be spending time with families. So take this time when you're sitting around, and I know it's, maybe you don't want to do it at the dinner table, but, after the dinner table and after dessert and when you're having the coffee, it's a good time to make sure you understand, mom, dad, grandma, grandpa, who did people in the family have colon cancer? Because this is really, really important. Because if you've had a family history of colon cancer, we know that you have an increased risk. and we actually would change our screening guidelines, right? So for an example, if you had, let's say your mom had colon cancer at age 48, we wouldn't be starting screening at age 45. We would be starting at screening 10 years earlier. Again, you see that 10-year number again. So if they developed it at 48, we say, well, we should start looking at anybody who is what we call a first-degree relative. So, children, brothers and sisters, and screen them 10 years earlier. So that's why we really, really want you to be able to know your family history so you can present that to your doctor, because it changes what we do. We also know that there's very good data on physical activity. And what we're talking about here is aerobic physical activity. Actually, the benefit, it doesn't take all that much. So, what I always tell my patients is you don't have to go out and run a marathon. That's not what we're asking for. Really, the equivalent of walking an hour a day, now that has to be a continuous hour, 3 days a week, already starts getting you benefits in terms of decreasing colon cancer. The more you do, the less you have to do, right? So if instead of, walking, you run, an hour, you may only have to do that a couple times a week, right? So anyway, the point is get out there, get moving, walk continuously. So, again, a lot of my patients like to say, well, I did walk for an hour, 5 minutes in the morning and then 15 minutes in the afternoon. No, you want to get the heart rate up a little bit. You don't have to get to the point where you're breathless, but you want to get the heart rate up and feel like you're doing something. And you want to do that for, at least 30 minutes, a day. And that's very beneficial. We know that, people who have very, what we call Western diets, so think McDonald's, have higher risks of getting colon cancer, because you can imagine the bowel and the colon, they spend a lot of time with the food that you eat. And so the more processed the foods, the higher fatty foods, those things will impact the colon, right? I mean, they're being bombarded with it all the time. So what we eat clearly impacts the colon, as you would expect. We know that, obesity is a risk factor, and probably it has to do with insulin resistance. And, the fact that, again, as people become more obese, insulin levels tend to rise, and insulin's a growth hormone, right? If you put insulin on a cancer cell, the cancer cell is going to grow. That's not to say you shouldn't take insulin if you're a diabetic, but if you can avoid these things, if you can work on weight loss, but quite frankly, I care about diet and exercise more than I care about weight loss. If you are out there doing stuff and, are moving more to, what we call Mediterranean style diets, but really fruits, all the stuff we know, right? Fruits and more fruits and vegetables and higher fiber foods, and you're exercising, those things are going to go a long way, even if you don't see your weight come down all that much. So I think we always have a little bit too much of an obsession on the scale. And what I would say is worry about the lifestyle changes, and everything else will actually take care of itself over time. Excessive alcohol consumption, alcohol is a poison, as much as many of us love it and, certainly use it here and there. It is a poison to the system. It's a poison to the liver, and it's a poison to the colon. And so again, it doesn't mean you have to abstain completely. It's just everything in moderation. And of course, tobacco, you can pretty much put cigarette smoking. If you ask a cancer doctor, does cigarette smoking harm X? We will tell you yes, because, again, remember, the reason cancers develop is because they develop mutations. And why do you develop mutations? Well, one of the reasons you develop mutations is that you are being bombarded with chemicals, right? And the cells are being bombarded with chemicals that, cause damage to the DNA. And cigarette smoking, we know, causes damage to the DNA. And so it's basically a game of Russian roulette if people continue to smoke, on where that damage is going to happen. But we know that lung cancer, of course, breast cancer, colon cancer, stomach, pretty much any cancer you can think of, cigarette smoking is harmful. So obviously, the message that you've heard, from many of us now going on 60 years is please, please, please find a way to stop smoking. There are a lot of, good medications and therapy sessions and other things people can do to really help them along those lines. So go ahead and go to the next slide. So I think we've got either I'm seeing double or the slide is double. My screen. Yeah, there we go. Go ahead. Go back one. Very strange. Get back again one more time. And then forward one time more. Well, here we go. So, this pretty much summarizes what I said, which is, increasing fruits and vegetables, getting that regular physical activity, stop smoking, reduce alcohol intake, screening, right? Because, again, you just don't know, some of us can do all the right things. I've had people who are incredibly healthy, marathon runners, and they get colon cancer. So, none of these things are a guarantee. So that's why, screening is the thing that will ultimately be the best chance that we can do to prevent this. We can go ahead and go to the next slide. So let's talk about, when we say screening, what are we talking about? So let's go to the next slide. All right. So, over the years, we had a bunch of different things and different ways to get screened. Fortunately, we've compressed it down to what we really think for the most part, at least as of today. Maybe we can talk a little bit about where the future could be going, and we will talk about that in a second. But as of today, there are really 3 ways to get colon cancer screened. 2 of them, are essentially suggesting that there might be, a cancer there. So again, blood in the stool. So there are special kits that, and we'll talk about that you can take home with you. And what we're doing in the lab is we are looking for blood. And we have very, very sophisticated ways with these tests to pick up blood. The other is, the one that you may have seen the commercial on. It's the cute little box that sort of jumps around, and that's Cologuard. And what Cologuard does is it incorporates part of the blood, looking at for blood in the stool, but it also is, very interesting looking at DNA in the stool. So we know that cancers, especially colon cancers, have a very specific pattern of DNA damage. We know what genes get damaged, and we can actually look for those genes, believe it or not, in the stool. And if we see those, then it's a strong suggestion to us that there might be something in there that has now had a mutation and could be a precursor or could be a cancer. Both of these tests, work very, very well. We'll talk about frequency. They differ a little bit. And the final test, is the colonoscopy, right? So the colonoscopy, the nice thing about the colonoscopy, right, is we get direct visualization and we can intervene, right? So if we see a polyp, we can take it out. Whereas the other 2 tests only tell us there might be something wrong. And if there is something wrong, then you have to get a colonoscopy. And I'm going to stress that because this is a problem that we see. People will go and get the stool blood test or maybe the Cologuard. It'll come back positive, and then they don't do anything. Well, that's not screening, right? It doesn't constitute screening unless you get a negative test back or you get a positive test back and then get a colonoscopy. So a positive test equals colonoscopy 100% of the time. There should be absolutely no question about that. So you got to finish the process if you're going to do, these other methods. So let's talk a little bit more about the pros, the cons, and different things. But from a big picture standpoint, what I tell, everyone always asks me, well, what's the best test to get? The best test to get is the one that you'll do. All right. So if it's, collecting the stool and that is, more appealing to you than getting the colonoscopy, understanding that you still might need one if you're positive, then do that test, right? If getting it done one and done and being done for 10 years is kind of what you want to do, then get the colonoscopy. They all work. They're all incredibly effective. You do what you're going to do, right? So there's no point in me prescribing a test that you have no intention of ever doing, right? That doesn't help anybody. So let's go ahead and go to the next slide. So now the nice thing about the things like the blood testing, what we call FIT, or fecal occult blood testing, or the Cologuard, is you get to do it at home, right? And it's not overly complicated, but there's a way to do it and a way to collect it and some special liquid that we put in there to help us basically find the genes and to help find the blood better. But pretty much you collect it, and usually there's a little bit of a kind of a paper mache cloth that can collect it, and you put it and you ship it away, and then you get an answer. Now I know nobody likes to talk about this, and nobody even the idea of thinking about taking their stool from a little piece of paper and putting it into something is kind of gross to us. what I always say, it always surprises me because, for someone who has dogs, and many of you probably do, we go out all the time and pick up their stool, with our little plastic bags and whatever, and don't think of anything about it. And then we say, well, what about doing the same thing with your stool and putting it in, a cup or on something? We all freak out. So, figure if you pick up your dog stool, you could probably handle your own stool. That's just my general theory of the universe. Now, the thing about the fecal call blood testing, because looking for blood is not perfect, right? We may not pick it up. There may be something sitting there and it's just not bleeding the day you do the test. Well, that's why we say we want that done every year. So by doing it every year, because remember, we still have that 10-year window. By doing it every year, we have learned that we can usually pick up, something that's bad by sampling more frequently, right? So that's the deal with that. Is it's not quite what we call sensitive, so it's going to miss things a little bit more. But if you do it every year, then you really get to the same results. The Cologuard, because it incorporates the DNA, gives us, is a little bit more what we call sensitive, right? Which means it doesn't have as many, so-called false negatives. Which means it tells you everything is okay, but there's something going on. So because it's a little bit more sophisticated, you only have to do this one every 3 years. Now we'll go kind of to the next slide. So obviously it's, the benefits are you do it in the privacy of your home when you choose. You don't have to get off of work, or have someone, to drive you, et cetera, to get a colonoscopy. There's no, dietary, issues. There's no bowel prep. So you don't have to drink the stuff that makes you empty your bowel. And again, almost all of these things are required. So colon cancer screening is a, what we call, an AB recommendation by the United States Preventive Task Force, meaning because of the Affordable Care Act, which we've just celebrated, I think the 14th anniversary of here yesterday, insurance companies have to cover, and they have to cover without a coinsurance the screening for colon cancer because we know it's so effective. So let's go to the next slide. So, we say cost, well, what are the downsides to it? You got to do it more often, right? So now you got to make sure you're doing it every year or every 3 years. And we're going to emphasize once again, critically, that if the test comes back positive, there's only one answer to that question, and it's colonoscopy. It's not repeated again. Oh, gee, don't worry about it until next year. You got to have a colonoscopy if the tests are positive. So absolutely critical. So, you kind of have, as I said at the beginning, do the test that makes sense to you. If the idea of doing something every year, you're like, I'm never going to remember doing it, then get the colonoscopy, right? As we'll talk about here as we go to the next slide. So colonoscopy, in theory is a pretty simple concept, right? We basically take a camera, a nice little flexible camera that gives us incredible resolution, and we look at the entire colon, right? And the people who do these are, GI doctors and sometimes surgeons are trained to look for polyps and look for things that are worrisome that could be polyps. And then when we're in there, if there's a polyp, they actually take it out. I mean, they basically just take a little, basket snare and they pull it out. Or if it's something more worrisome, they can biopsy it and let us know what we think it is. If it's a polyp and it's taken out, you're good, right? That thing is never going to become a cancer. So, that is really the nice thing, about colonoscopies is that they allow us to, go in there and not only diagnose, but actually to treat in one setting. As I said before, because of this 10-year rule of, what it takes from something to go from a normal colon to cancer, and because the colonoscopy is such a good test because we get, we can see everything, you only have to have this test done every 10 years, right? So that's one of the things about it. So we can go to the next slide and kind of talk about benefits and risks of these things. So, in terms of, getting a colonoscopy, it does involve a little bit more, right? And this is where I know we've run into a lot of problems as a healthcare community, is there are a lot of places where people can fall through the cracks in this. And so it's very important that everyone understands, what the procedures are. So the first thing is you understand what you're getting yourself into, right? That, you're going to have to go in, you're probably going to have to take the day off work, someone's going to have to drive you, that you're going to have to, drink something, the night before, 2 nights before, because, again, put yourself in the place of the person doing the procedure. If we go in there with a camera and all that we see is stool, we can't see the walls of the colon, right? So we can't see the polyps if they're blocked. So we really try to get the colon cleaned out. So that's why we make people drink stuff. Now the preps have gotten, again, I've done it twice. The preps have gotten much better. Often you don't have to drink as much as you used to have to drink in the past. We split it up in a couple different, a couple different rounds of drinking. So we're not asking you to drink 4 gallons at one time. Having said that, it is what it is, right? I mean, the whole goal of it is to clean you out. So you are going to get, a little bit more liquid, coming out. So it's probably not, you probably don't want to do the prep and go out and, play volleyball or, go to a rock concert. But, as long as, but you can schedule it, on your schedule and, just prepare to be around at home that night. And it's not miserable. This is not like having the flu diarrhea, but yeah, there's going to be kind of, liquid that because we got to get stuff out of there to clean it out. So you can go ahead and go to the next slide. So again, you want to make sure that, we'll give you kind of instructions on it about, changing things in your diet a couple days before. The big thing is we really like to avoid people drinking or eating anything that's red. So like things like red Gatorade, because you can imagine red to us is blood. So don't scare the colonoscopists. And then, we try to, again, start removing the amount of stool that's going to be in there by doing things like, drinking a little bit more, having more of a clear liquid diet, right? So the more you do that, and if you do that a couple days before, if you really start limiting the big things, and the big solid foods, the easier it is going to be to clean everything out, and then again, we do this in kind of a split dose. So we do kind of half the day before, half the morning, the morning of, and then you go to the clinic. And then usually what happens there is for colonoscopies, you actually get a little bit of sedation, what we call twilight. So for most people, you won't even remember the colonoscopy. You'll talk to the anesthesiologist, and then the next thing you know, you'll be in the same place, woke up, and you're going to be wondering, when is it going to happen? And they're going to tell you, you're done. That's what happened to me. I swear I didn't know that it even occurred. Except maybe in a little dream state, and it doesn't hurt because of the sedation and all of that. You really aren't going to feel this, and quite frankly, many people won't even remember that they had it done. So next slide. So the benefits, it's a one and done for a 10-year period, right? So if you're that person, and I'm that person, right? Trying to remember to do something every year, boy, that's a lot, so you get it. If everything looks good, you're clean for 10 years. Again, it's not only diagnosis, but it's treatment. And for the same thing, colonoscopy is considered a valid screening tool, and patients, insurance companies are legally required to cover it, without co-insurance. So it shouldn't cost you anything to have a colonoscopy because we want to prevent cancer, right? It's in all of our best interest to prevent cancer. The next slide. The downside to it, well, it takes a little bit more of your time, right? You got to travel. You got to do the bowel prep. You got to have someone take you because of the sedation. We don't want people driving afterwards, right? So it does require a little bit more lifestyle change and a little bit more adjusting your schedule than collecting the stool at home. But you can schedule it in advance, know about it, and, hopefully most people in your lives and your work and everybody will be understanding that you're doing something that's very, very important for you, because none of them want you to get cancer either. But that is, that is certainly the issue, is a little bit more time consuming for you than it would be just to get the stool-based test. Go to the next slide. So what do we talk about? Well, number one, it's a common cancer, right? Number one cancer among non-smokers, becoming the number one cancer death for people under the age of 50. And if it develops, and you end up having to see me, we can still cure colon cancer in the vast majority of patients, but there are some people who will die from their cancer because it progressed. And unfortunately, a lot of my clinic are people who, lives have been ended short, because they did not get, appropriately screened. It can be prevented, no question. There is no debate about this. Nobody, is going to sort of say, well, the data aren't clear. No, the data are clear. You do what we just talked about today, and you have, you know, a very, very low risk of ever developing colon cancer. There are options for it, right? So you decide what works for you, right? Whether it be collecting stool at home every year, collecting stool and, you know, sending it away to a company in the Cologuard case, or getting that colonoscopy. So whatever works for you. But again, you know, if you didn't hear me, if you do one of the stool-based tests, right? So that would be the FIT or the Cologuard, and it's positive, the next thing out of everyone's mouth should be, when are we scheduling your colonoscopy? And that schedule should happen, you know, relatively shortly thereafter. It is not something to blow off or hope that if you do it a second time, the test will be better. You see it once, you got to have the colonoscopy. For the most part, it is the law of the land at a federal and state level that insurance companies pay for colon cancer screening and pay for it without charging you. Okay, so very, very critical. The one that's not on here, and I'm going to repeat it again, know your family history. Please, please, please use this opportunity to talk to family members and find out if people had colon cancer in the family. It amazes me how often, you know, I'll see patients and they didn't know, you know, they'll see me for colon cancer. I'll ask about family history. They won't know it. And then they'll go back and talk to mom or dad and say, oh, well, actually, you know, somebody did have it, right? Or mom had it and we just didn't know. So anyway, it's really, really important you know that, because that piece of information is critical to us in order to advise you on the best screening and how often you should get screening and at what age you should get screening. So, you know, you can do a once-a-year test, you can do an every 3-year test, you can do a 10-year test. We don't care what you do, just do one of the above. So
Awesome. Thank you so much, Dr. Polite. We all learned so much. Thank you so much for being here.
no, my pleasure. This is, you know, very, very important to me. Like I said, I've always, you know, if I can be put out of business, you know, let me go do something else in my life. You know, if I don't have to see another colon cancer patient because it's been prevented, you know, I will be the happiest person in the world. So, you know, as I said at the beginning, your goal should never, you know, never to have to walk into my clinic and see me.
Absolutely. Thank you.
Thank you all.